All right, letting folks to sort of trickle in. Good afternoon, at least if you're on the East Coast. Brandon Gare with the National Minority Equality Forum here. Started a few minutes late as we want to make some time for Congressman Gomez, who'll be joining us in just a couple of minutes. But welcome to our Friday webinar. As you know, if you've been following NMQF for the past 4 years now, on Fridays, we use that Friday early part of the afternoon to sort of just educate or talk about some topics that are of interest to us and hopefully to you guys. And we have a really big one this afternoon. Medicare Part D changes in 2025, what patients, policymakers, and Hill staff need to know. And this is, we're always trying to educate and learn ourselves. And we're going to go ahead and have Michael Ward, who is the Vice President of Public Policy and Government Relations for the Alliance for Aging Research. He's going to moderate today's panel. We were discussing earlier, Michael this isn't his first rodeo. He's done this with us before, lead some discussions, not only in this venue on virtually, but in person at NMQF. So many of you should be familiar with him and know his knowledge and, know of his knowledge and the work that he's done. So without further ado, I'll just go ahead and turn it over to Michael, who's going to provide remarks and introduce our panel. So, Michael,
Uh,
welcome.
Thank you,
Welcome
Brandon.
back.
I appreciate it. I appreciate the National Minority Equality Forum for this important opportunity just to talk about the changes that are coming to the Medicare Part D prescription drug benefit in 2025. Really, the biggest changes in the Medicare Part D program since it started, around 20 years ago. So there's a lot to kind of get through, and especially for beneficiaries. And I'm excited to talk about kind of what beneficiaries need to know today because, when we're talking, all of us around this table, we all work with patients, we all work with the patient community, and when it comes down to today, that's what's most important is like how these policies actually impact, the people in our the people that we represent, the people, our loved ones, our own parents. And grandparents if we're lucky enough, for them to still be around. And so I'm excited to talk today. I know that Congressman Gomez will be joining us here in just a few minutes, but just wanted to take a few minutes to introduce my co-panelist, Jennifer Dexter from National Health Council, where she serves as the Vice President of Policy. Jennifer's been at the NHC since September of 2019, and really has a long history of advocacy, working at Easter Seals, and really leading efforts in Congress to assure, appropriations funding for federal programs for individuals with disabilities and older adults. So she's a real champion. I know many of you know her. If you don't, then you should. So after today, you have no excuse. I'll just throw it to you, Jennifer, just to see what ask what you'd want to get across today.
Sure. Thank you so much. I'm so glad to be here. Always such a good Friday afternoon discussion to have. I would start by just saying, for those of you that don't know the National Health Council, I'll give you a 2-second overview. We were created by and for patient organizations about 100 years ago. And the idea is to bring diverse organizations together to forge consensus and drive patient-centric health policy. Our main focus is on access to affordable, high-value, sustainable, equitable healthcare. We have about 180 members, primarily made up of the patient advocacy community and led by that community, but also incorporating groups that are health-related associations and nonprofit organizations, from folks like provider groups, research groups, family caregiver community. We also have business representation from the biopharmaceutical device, diagnostic, generic drug, and payer organizations. So we're a little bit of an outlier that we represent kind of the entirety of the health ecosystem, but are always led and driven by the patient community. So I'm really happy to be here today to talk about all these exciting changes that are coming.
Well, thank you, Jennifer. And just a programming note, I know that we just popped it in the chat box, but we definitely want this to be as interactive as possible. So please, if you have questions during today's webinar, please make liberal use of the Q&A box there at the bottom. Ask questions as we go along. We'll try to build some as we go, and but we'll also kind of have a more concentrated Q&A session at the end. So just maybe while we're waiting for waiting for the congressman to join, I'm just going to present just a couple of slides that really kind of talk about, at a very high level, the Medicare, the changes that are coming to Medicare, to really kind of set the stage for his remarks. So let me just set up a screen share for just a second. Here we go. All right. So just to level set, just want to cover at a high level how prescription drugs are paid for by Medicare. So Medicare provides health insurance for individuals that are age 65 and older, or that have a disability and qualify via that route. And there are kind of four parts to the Medicare program. There's Part A, which covers hospital, usually hospital stays and a lot of your post-acute care. Part B, which is primarily associated with physician payment, but also some prescription drugs are paid for that. So usually drugs that are administered by a physician in a doctor's office or at an infusion center. There's Part C, which is Medicare Advantage, the medical benefit, and then the Part D program, which is the prescription drug benefit. And this covers drugs that you tend to, when you think about prescription drugs, that's usually what you think of. You think about pills, you think about self-administered drugs that you pick up at the pharmacy counter in your local community pharmacy or to CVS or Walgreens. Also it's, even though we might say at the pharmacy counter during today's presentation from time to time, this also is inclusive of other areas that you might get a script. Like I know a lot of people get their drugs through mail order. Some folks, due to the drugs that they take for their condition, go through a specialty pharmacy. So there are different routes, but just for kind of the sake of visualization, we may say at the pharmacy counter from time to time. And Part D drugs are paid. They aren't. They don't get a check directly from the Medicare program. These are paid through insurance plans that operate these prescription drug plans. So Medicare Advantage plans often have a prescription drug benefit associated with them. They have an option for a prescription drug benefit to be associated with them. But there are also standalone prescription drug plans in Part D. So if a beneficiary is not Medicare Advantage, if they continue to stay as a participant in fee-for-service Medicare, for example, they may choose a standalone Part D plan. And that'll be important just in terms of how some of the impacts that we're seeing and from the Inflation Reduction Act and some of the areas of the law, because those plans are impacted a little bit differently. And then depending on an individual's plan, their out-of-pocket costs vary based on each insurance design and formulary. So you may be familiar that some Medicare Advantage plans may have, they may not have copays for some drugs. So there's many permutations that impact kind of drug costs. And so just to talk a little bit about what the changes that are coming as a result of the Inflation Reduction Act, which was passed in 2022. There were a number of changes for affordability. We've already seen a handful of those take place. We've seen the cap on insulin prices take place, the elimination of vaccine copays, and other benefits take place. But kind of the two of the biggest pieces in terms of how beneficiaries are going to experience of the IRA and their healthcare experience in Medicare are going to take place in effect on January 1 of this upcoming year. So the first is an out-of-pocket cap, so an out-of-pocket limit on expenditures on Part D drugs. So again, these are the ones that you get, quote unquote, at the pharmacy counter. So no beneficiary will pay more than $2,000 for Part D drugs in 2025. Now this is a huge win because before the IRA, there was no out-of-pocket limit. So you had individuals that were paying, especially if they may have had cancer or another expensive condition, they may have been paying $5,000, $6,000, dollars a year in their prescription drugs on up. So this is a huge win for beneficiaries. And then the second piece of it is the implementation of a new payment option called the Medicare Prescription Payment Plan. And what that plan allows beneficiaries to do is to pay the cost that they accrue up to that $2,000 limit in monthly payment installments. And we'll get into some of the parameters of that program. It is new. It's an opt-in benefit, so beneficiaries have to proactively choose to participate in it. So it's going to be really important for beneficiaries to understand the program, you know, and then understand how to activate it if they do want to choose it. So these programs join other programs that have already been in place to help beneficiaries afford their medications. You may be aware of other programs, including Medicare's Extra Help program, which helps provide additional subsidies for lower income beneficiaries. And it's also important to note that the IRA expanded eligibility for that. And I just want to
There's a
check.
Q&A, Michael. We can jump in. I can answer that if you want.
If there's questions that popped up,
Yeah, there's one just asking if Part D is mandatory and how people enroll in it. It is not mandatory, but is a valued benefit within Medicare, obviously. And you would sign up for it separately, but at the same process, you would go through signing up for your overall Medicare plan through Medicare.gov or a broker. And it would have its own separate enrollment process. So just wanted to kind of flag that question, that Part D is something that is not mandatory to be included in a plan, but something that is most people take great advantage of.
Yeah, I'd say, forgetting exact numbers, I know that there's between 60 and 70 million beneficiaries that are enrolled in Medicare, and I believe there's around 55 million beneficiaries that are enrolled in the Part D program. So the vast majority of beneficiaries in Medicare do participate in Part D, but that's a great question. Okay, and then we'll move forward to the next slide. So I just want to talk a little bit more about that Medicare prescription payment plan, because it's kind of it's a new program, just like the out-of-pocket cap. It does differ in that it isn't automatic. So the $2,000 cap, every Part D beneficiary will have that benefit. You don't have to sign up for it. You know, if you spend $2,500, the beneficiary's out-of-pocket liability, how much they pay out of pocket will end at $2,000 for the year. So that's fairly straightforward. There's always devils in details, but that's relatively straightforward. The Medicare prescription payment plan is a little different. So as I mentioned, for out-of-pocket costs that are less than $2,000, beneficiaries are going to have the option to spread out their cost in monthly installments. You can think of this a little bit like Klarna. So I have a diagram here on the left where if you have, let's say you accrue $1,200 in cost in January, and this is an oversimplification of the math, but you would have 12 payments over the year, so from January through December, to spread out those $1,200 in costs. So this is a big deal, just because I know that $1,200, even though $2,000 limit is a huge gain. Like there's these dollar figures like $1,200, $700, $500, $400. These are still barriers to people being able to get their medications, right? If you're living on your Social Security check, and you kind of have a set amount of money that you're working with each month, and having a huge kind of additional cost, especially in January when you have a lot of other premiums that reset and all these things, that can be a real challenge to people staying on their medications. So, and that's kind of one of the reasons why these programs are so important, is just because we want to make sure that people are able to adhere to the care plan that their providers set out. Because if they don't, if people don't end up filling their prescription, If they fill it, but they, go home and split their pills, that isn't according to the doctor's advice or things like that, then it can result in harmful outcomes for patients. And not only is it harmful for patients in terms of, they may get sicker or they may decline more quickly, it can also result in additional costs for the Medicare system if individuals end up in the hospital. And hospitalizations are very expensive. So it's very important, to ensure that we're doing everything possible to ensure that people are able to get and afford the care that they need, right? So this plan helps people if they have $1,200 in cost in January, for example, spread out those costs in roughly $100 payments each month for the rest of the year. And so that's very simplistic, but I think the variable that it's going to require a lot of education for patients is that this isn't like a credit card and that like you have kind of a long period of time to pay it off. This resets in December of each year. So if you are enrolled and you have cost in January, you're going to have 12 installment payments. But if you are enrolled and you first incur cost in July, you're going to have 6 payments over the course of the year, the rest of the year, in order to spread out those costs. So if you instead incurred those $1,200 of cost in July, you would have $200, give or take. There's some math that gets in the way there. They'd have fewer installment payments to spread out the costs that they incur over. So that's an important thing. But as you can tell, this could be helpful to a lot of beneficiaries, but there's a lot of effort, not only in terms of helping beneficiaries understand kind of these differences related to how long they have to spread out payments depending on when they enroll in the program during the year. But there's also a big effort that's going to be needed to figure out how to convey the point that beneficiaries have to enroll with their Part D plan. They have to enroll directly with their provider, if it's Aetna or United or Humana, whoever is operating their prescription drug plan. They have to tell their prescription drug plan at least 24 hours in advance before they go to the pharmacy counter and pick up their drug that they want to enroll for this to take place. But on the flip side, you don't have to enroll at one point of the year. You can enroll at any point during the year. So that's an important gain, just because at the same time, there's a lot of benefit. Even though beneficiaries, have chronic disease, they may know that they're going to deal with costs at the beginning of the year and know that this will be beneficial to them. There's also a lot of times when people change medications in the middle of the year, or they get diagnosed with something new, mid-year, and so they end up having to go to a medication that's more expensive, and it may have not made sense to participate in this installment payment plan before, but it may then. And so there's a lot of education. So I'm going to turn it back over. And we're joined now by Congressman Jimmy Gomez. Excited to have you still stop screen sharing and do a quick introduction for a congressman. So glad you could join us today, Congressman Gomez.
Thank you so much. First, thank you for having me. And thank you to the National Minority Equality Forum for hosting just this important briefing. I represent downtown LA, the 34th district. And one of my district is really diverse, very working class. So I was happy to help pass the Inflation Reduction Act, which was a landmark bill. And it was a huge win. Like, people forget how big of a win because they often just view certain parts of it. But I think we made huge investments and reforms to help working families, seniors access healthcare, address our climate crisis while ensuring all the benefits of a green economy are available across the country, and not just for the people that can already afford those products. And I think that this actually has helped lower the cost to working people. One of the issues I dealt with was the USDV tax credit, the first of its kind, and federal legislation. I took the idea from California because we're often ahead of the curve, and now people are buying cars, electric vehicles, for $15,000, $11,000, and they're getting comfortable with the idea of driving an electric vehicle, and that's how you get mass adoption of this kind of technology. People have to feel comfortable. They have to understand that it's a bargain and that it's not just for the higher income folks. And then at the same time, when it came to health, uh, it was a huge investment in our communities, bringing down costs and capping. The one issue that people always bring up, capping insulin at $35 a month. Like people are blown away. And I know that's mainly for Medicare, that's just for Medicare recipients, but it is a big deal. And then allowing Medicare to negotiate those drug prices, the idea was always simple. Allow them to negotiate Medicare drug prices, and it's going to have an impact on the entire market for those same drugs. So you start off with 10, then you're going to do another 10, and I think that that's going to be a profound savings to individuals across the country. And in my district alone, 48,000 Medicare beneficiaries will see savings totaling 4.7 million this year alone and 7.3 million for next year. So we know that like when you start saving a few $100s here, a few $100s there, you lower the cost of electricity, transportation, medicine, healthcare. You really do have a help working class people get by. And the one thing people talk about right now, affordability, affordability, affordability. Things are too expensive. And honestly, I noticed it. So I noticed that. And when you're pinching every dollar, um, you're more sensitive to any kind of price fluctuations. But we also saw the impact of the enhanced child tax credit. It's something that that cut child poverty from anywhere from 40 to 60% because it did two things. One, higher um, amount of child tax credit, and then also more. You didn't have to necessarily work in order to get it, and then it was also advanceable. You got it every single month. You know, working class folks don't live on a year calendar. They live month to month, even day by day. So when they get $250, $300 per child per month, well, you're just paying for the family's groceries. You're paying for their utility bills. You're paying for the basic necessities. So this is a huge win. We got to get it done. But I believe it also has to include an advanceability. People need to get it monthly and not just when they file their taxes. And I think in my district alone, it was about 113,000 roughly children that benefited from this poverty. I mean, from this policy. So, and I think that's kind of some of the ideas we have to look at. How do you still make policy efficient and effective? We always talk about producing results. Republicans talk about producing results. Well, this produced massive results. You know, most people forget that original child tax credit was actually a Republican idea. We just made it better. So I want to just say you know, this is what I think we're talking about today is, you know, Medicare prescription payment plan. How do we cap out-of-pocket costs for seniors? How do we cap insulin? How do we just lower cost? And a lot of it is from these health provisions in the Inflation Reduction Act. And next year we're gonna have a big fight next year when it comes to the expiration of the Republican tax cuts, the Donald Trump tax cuts. And of course, they gave permanent tax cuts to the largest corporations, but then for the working person, all those tax cuts expire. So we have an opportunity to rewrite our tax code to make it more equitable so the benefits just don't go to the top 1/10 of 1%. That's where you had 6% of the benefits of their tax cuts went to the top 1/10 of 1%. If we have an opportunity to redo our tax code, we can put more money into healthcare, underwriting the subsidies for plans through our exchanges, right? That expires. So there's so much opportunity, but we can't let that opportunity go by. And I know if Democrats are back in the majority, we're not gonna let it go by because that 2017 tax cut really didn't do what they said that was going to do. And then at the same time, it never paid for itself. It actually cost about 2 trillion when they said it was going to pay for itself, and they said it was only going to cost 1.5 trillion. And in the end, it added a lot to our national deficit and debt. And then Republicans use the growth of that debt, the growth of that deficit, to cut social programs. We're not going to let that happen. We're going to be smart about it. We're going to be pragmatic, but we're going to reinvest in housing, health, and of course, when it comes to combating climate change. So I just want to say thank you all for doing what you do, making sure that, and then a lot of these things take effect next year, so we got to make sure people know about them. So thank you for inviting me. Have a good briefing, and keep up the great work.
All right. Thank you so much, Congressman Gomez, and thank you so much for all the work that you're doing on behalf of your constituents in the 34th.
Thank you.
All right. Well, we'll transition back to I do have one more slide, and then we'll kind of switch to more discussion-based format. So I was just talking a little bit about kind of how this differs from in that patients and beneficiaries have to opt in. So as I mentioned, beneficiaries opt in directly with their Part D prescription drug plan insurance provider. They can do this online, by phone. There'll be a mail-in option for many plans. And then beneficiaries can start opting in, say that, hey, I want to use this monthly payment plan as soon as open enrollment. So open enrollment starts less than a month from now, October 15th, and it runs through December 7th. But again, if it's not right, if a beneficiary during open enrollment or before the year is, still isn't sure if this is the right plan for them, if they decide later in the year that they want to use it, they can just let their plan know at that point that they want to opt in. And how it's going to work is the beneficiary won't pay anything at the pharmacy counter. So they'll go, if they go up, they pick up their script. They won't pay anything, but they will receive monthly bills directly from their insurance plan, for any costs that they accrue. So plans are encouraged to offer multiple payment options, such as electronic fund transfer or by check. However, as I mentioned, beneficiaries are going to need to plan ahead to use the benefits. So they have to opt in with their drug plan at least 24 hours before picking up their medications to allow that election to move through the system and for the pharmacy to be able to see it. And you won't be able to sign up at the pharmacy counter in 2025. That is an area that the Alliance is working on, that the NHC and a lot of other patient advocacy groups are working on as well. And so, hopefully that will change in the coming years. But for 2025, that is something to know. So Jennifer, maybe we can I can ask you a few questions about this new installment payment option. So I know we talked a bit about the out-of-pocket cap. So how do those interact? So is there any interaction? So is there any chance that someone may have to pay more out-of-pocket annually if they opt into this payment installment option?
Michael, that's a great point, because I've actually gotten a couple questions about that as I've talked about this. And there is no beneficiary will ever pay more than the $2,000 cap. And whether you choose to spread that out over the year or not, the cap is kind of separate from that. So that is a little sacrosanct now, hopefully.
Yes, it's definitely good to know that there's like that maximum, and you shall not pass beyond that.
Exactly. Well, and on top of the smoothing, it helps beneficiaries plan out their year. So if you have $500 in January and $500 in March, even if you're spreading it out, you will know at some point you have maxed out, which is a new and exciting thing.
Yeah, and one thing I do want to note so that's the limit for 2025. It will be something that will be updated annually. So that's it's pinned to growth in the Part D prescription drug total spending. So if total spending in the Part D program increases by 3%, then the cap may as well. So it's just important to note for future years that we're starting with $2,000, but it will be something that we'll continue to need to keep an eye on to make sure that this remains affordable for beneficiaries. And then I guess kind of what these parameters around, depending on when you enroll in the year, that impacts how many payment installments you have to pay off the amount that you accrue. Could you share a little bit about who you think the plan, this payment installment option may be most helpful for?
Absolutely. And I want to caveat this at the beginning by saying there's a lot of discussion in the legislation and in the regulatory work and out of CMS and amongst ourselves around who is going to be most likely to benefit from this. And at the end of the day, it's really going to be about individual circumstances and giving people the information they need to understand what the right decision for them might be. But there are some things we know. So for instance, it's likely to be beneficial for almost any beneficiary, but especially those with the higher drug costs. So those folks who are in that $1,000 to $2,000 range are more likely to be able to spread it out. If they're relatively inexpensive drugs on an ongoing basis, they're already kind of spreading it out in a way because they're, if you have a $100 per month prescription versus $1,000 in January, may make sense to just pay it instead of spreading it. So those are folks who may choose not to participate in it. Michael mentioned earlier some of the extra help programs, state Medicare savings programs, other plans that are helping reduce costs may be a much better option for people, particularly folks who are of significantly lower income. They may actually be better off going into one of those programs that doesn't offer smoothing but reduces their costs tremendously. So that's something people will have to consider. I always say, like, what people are talking about is that it would be potentially less useful for folks who have like a lot of payments later in the year, who have fewer months to spread it out. But I keep using the example of, my parents or grandparents. They may have a fill in October that they want to spread out just to create a little breathing room in their budget for Christmas presents. Like, that is a perfectly appropriate decision for them to make. So even though we're saying kind of it may work better for some people than others, I do want to emphasize that anybody can take advantage of it, and there will be people for whom individual circumstances may make them make a choice that may not, from the outward looking at it, make sense. So just want to flag that.
Right. No, I think that's exactly right. Is that there is no one Medicare beneficiary. So everyone's circumstances differ, and I'm just glad that that a program like this is available as an option for those as long as they know about it, as long as they know that this is an option for them, that they can be able to choose. And then are beneficiaries able to disenroll during the year if they enroll and they say this isn't working how I want, or this isn't right for me?
Absolutely, that is always an option. If their circumstances change, they have a little bit of a windfall and want to pay everything off at once, or it just works better for them to not have it, they can do that. It is important to note, though, that they still owe the balance. So they what they've already agreed to pay in the smoothing program, they can either they could pay it off, or they can pay it off in their, continue their installments and just not spread out any future drugs. Any additional drug costs, you go back to the traditional way where you pay at the pharmacy counter, whatever you owe during that transaction. We have a couple Q&As, Michael. Do you want to take a minute on those?
Yeah, we can start those. Sure. Okay.
I noticed they were building up.
Yeah, so. Yeah. We'll take a couple now, and then we'll take a couple a little later.
Yeah.
So I think that this last question relates well with kind of one kind of final question about this payment plan option that I had. And so the attendee asked, is there interest on payments in the Medicare prescription payment plan if they don't pay by the end of the year? And that's one of the very cool things about this, is that This isn't like a financing thing where, you're taking out a loan or like a credit card. This is a zero interest payment option. So,
Mhm.
if you charge those $1,200 in January, it isn't like by the end of the year you've paid $1,500. You're going to pay $1,200. As long as you don't add additional, uh, you know, charge more things to the payment plan. And so I think that's a really important point. But I think it raises a good question. It's like, what happens if a beneficiary misses a payment or is late for a payment? So Jennifer, I'm not sure if what you can
Sure.
share on that.
It's actually a very interesting. This was a lot of back and forth in kind of the creation of this program. But right now, what happens if the individual doesn't misses a payment? The first thing, and this is really important to know, is that there is a grace period.
Hmm.
So you have your monthly amount that's due, and then if you don't make that payment, there's a 60-day grace period to make up that missed payment. So if you know, forget about it 1 month, or need it, your Social Security check comes in later than planned and you're late, nothing, and you pay it, nothing will happen for those 60 days. But then if it starts to build up, really what happens is that nothing happens to your Medicare coverage, but you are essentially removed from your ability to participate in the smoothing the Medicare prescription payment plan. So you still, so let's say you have $500 left that you owe throughout the year. If you miss a payment, you still owe that $500. And the plan can remove you from your ability to spread out any future payments. So the next time you had a prescription filled, you wouldn't have the option of spreading it out. You'd have to pay at the pharmacy counter. It doesn't affect your insurance coverage, and this is something we're all going to have to be really focused on. So it's not like you get kicked out of Medicare or kicked out of your Part D coverage. It's just your ability to participate in that spreading out throughout the year.
Yeah, no, that's another kind of great protection in addition to no interest. This doesn't impact individuals' eligibility. So if you're late for a payment, I mean, dealing with, working with individuals that are older or, that do have a chronic condition, it's, a hospitalization can happen that, makes it where you miss a payment and then you're worried about it. With this program, you don't have to, worry about that so much just because there is that grace period. And once,
Did Michael freeze for everybody, or is it just me?
oh, it looks like you froze for me, so maybe it's on me on my end. Okay, okay.
I'm
All right,
back.
back. Okay,
My
all right.
apologies. My
Didn't
apologies.
know if it
My
was you or
Wi-Fi.
me.
I think.
The fun of Zoom. And so that's important. And just wanted to address another question. There's a couple other questions that are in the box that I think parlay well with some topics we're going to cover here in a few minutes.
Mhm.
But another question we received in the chat was, where will the bill come from? Will it come from the pharmacy or the Part D plan? So it's the latter. It will come from from your health plan.
Mhm.
So so you won't get a bill from Walgreens, for example, but later on, a few weeks later, you'll get a bill for kind of all the drugs that you charge to the Medicare prescription payment plan that month, and you'll get a statement from your insurer saying, this is how much you owe, this is what your costs are per month, and then obviously kind of how to pay, kind of what you owe to the plan. So it will come from your insurance plan.
I think
So a couple,
I just want to add. I think that's one of the biggest consumer behavior changes we're going to have to work on, is making sure people understand there's going to be a new bill coming from your insurance company and how to understand it and read it. So.
yeah, exactly. So it's but again, there's a benefit in that you don't have to pay at the pharmacy counter, but you will kind of have an accrual statement at the end of each month, and with information about what your costs will be for that month, and as well as in future months, assuming that there aren't additional charges. So, I think just we'll hit pause on the Medicare prescription payment plan discussion now, because there are other changes I think that the beneficiaries should be aware of as heading into open enrollment. And these are, they can be unintended consequences or just, whatever the case may be. But there could be some changes I think that impact. What prescription drugs are covered and where they may fall on formularies. And so, Jennifer, I'll just ask you if,
Sure.
could you share a little bit about what beneficiaries should be on the lookout for, in open enrollment and next year?
Absolutely. I think a couple things. There's, as with any change, I'm old enough to have been around when Part D started, and remember sending, we were literally on buses driving around the country, you know, helping people understand this. So there's going to be a lot of growing pains. There's going to be a lot of tweaks that can be made. I always describe this as a pressure valve. There are what are the things that we will need to watch to make sure the pressure isn't building up over here or causing issues over there, and how do we release that pressure to help get to them. So from the patient community's point of view, the thing we're watching most closely is what are the changes that are going to happen for where drugs are put on the formulary, which means kind of what level of coverage they have for individual plans, and what kind of financial constraints are plans dealing with, where they end up getting a little tighter with things like utilization management. So are things having to go through step therapy more often? Are things being denied? Those kinds of things, from prior authorization. There are some reconfigurations of the Part D program that realign some of the incentives. So I think we're going to have some issues going forward, just making sure that we know what's happening in terms of coverage and affordability for people. The $2,000 cap will be huge for people, obviously, and it won't matter where they are on the formulary. I did see that was one of the Q&A questions. Your cap is your cap. But it may matter in terms of what they allow into the coverage piece. So it's really, really important that we make sure that we are talking to Congress, that we are talking to CMS, that we are talking to patients and collecting that information and looking for those trends, looking for those issues that might need tweaking, making sure it's working for the individual consumer. And I fully expect some hiccups next year, and we will be addressing those. Some of them will be implementation issues. Some of them will be issues around where incentives are in the program and realigning them. But it'll be really important that we collect that, we share that, and we act on it.
Yeah, I think especially just because from year to year, once Medicare beneficiaries join a plan, they generally do not switch plans. Like over 90% of beneficiaries end up staying with the same insurance coverage from year to year. And so with all these changes, with a $2,000 cap, which applies to all plans, that's the most a beneficiary have to spend no matter which insurance plan they go with. With these parameters that you were talking about, Jennifer, there's going to be a lot of changes to, a beneficiary may have selected a plan in the past because it was the cheapest option for the prescription drugs that they take. And what it's important to note is that may not be the case anymore. In next year, like another plan could be a better fit for them in terms of affordability. The drugs that they're currently on may have changed positions on their current insurer's formulary. So it's going to be really important, more important than ever, really, for beneficiaries to evaluate their options during this open enrollment season, to evaluate do the work to do a little bit more legwork to understand what their costs may be and a few different alternatives and shop around, because a better deal may be out there. And so that's, I think that if we're taking like one of the takeaways from this webinar, that would be something that I would encourage, Hill staff and others to emphasize as they're working with their constituents. And really on kind of that $2,000 cap, yeah, that's such a great question in terms of it. Does it apply only to drugs on the formulary? Because that's definitely just something that I want to check, just because just check with your plan. Make sure that if you are taking a drug that isn't on formulary, just make sure that you understand what the ramifications are of that. But generally, if you can, while you're in this open enrollment season, try to find drugs that are on formulary. That way, that you're covered. And generally, if you're taking drugs that are covered by formulary, then they'll be have lower out-of-pocket expenditures as well. So I think we have a few questions in the chat. Again, we have just a few extra minutes for Q&A, but I want to, before I get to those questions, just want to note there are additional resources that are available. As we kind of talked about, there's going to be a huge educational effort that's needed to ensure that beneficiaries are aware of these changes. Frankly, there are when Medicare Part D was rolled out 20 years ago, there was a huge marketing budget to talk about all these changes. Or CMS does not have the same level of resources on the educational front to kind of talk about these new changes. And so groups like the Alliance, groups like National Health Council, groups like Lupus Foundation of America and MapRx, which is a coalition of patient advocacy groups that are working on patient affordability issues. When we're all producing materials and resources. So for, I know that I believe that Ashley shared it in the box, but if you want to check out the Alliance's resources, they're available at loweroutofpocketcosts.org. So if you go to that website, we have some cool resources, including a detailed explainer video. It's like 4 minutes long that kind of goes through what the cap is, this Medicare prescription payment plan, things that beneficiaries should consider as they're thinking about if they should participate. There are links to Medicare.gov and other resources from partners on enrolling Part D for 2025. The Medicare prescription payment plan has a homepage at medicare.gov/prescription payment plan, and that was just posted a couple weeks ago. One thing I will note on there's I think the video is pretty good. We're gonna be honest here. There's a wizard on there, that interactive wizard, that asks a few questions and says if is this a good fit for you. I think some of the feedback that we've received from patient community is that tool may underestimate how many beneficiaries are likely to potentially benefit from this. As Jennifer talked about, everybody has their own individual circumstances, and so I think it's worthwhile for all Medicare Part D beneficiaries to know this is an option, and then be able to assess for themselves if it's right for them. I mentioned great partner organizations like National Health Council. Their website's nationalhealthcouncil.org. MapRx is at maprx.info. And then also resources that I think that are underutilized in some ways are state insurance, health insurance assistance programs. There's one in each state, and you can find out more about the one that's relevant to your state at www.shiphelp.org. Jennifer, maybe I can just ask you to see what questions we still have in the Q&A. And again, if they have any remaining questions, feel free to drop them in the chat box, and we'll try to get through as many as we can in the next few minutes.
Yeah. I think the one about who's going to help people plow through this, I think, is really important. And Michael just shared some of the resources and organizations. And CMS is going to do a lot of work on that, but it's going to have to be all hands on deck. Starting with the explaining it and making people comfortable with particularly with the prescription payment plan. Because I don't know about you, but the folks I know who are on Medicare are always on the lookout for things that are look, sound, might be fishy, sound too good to be true, because they get a lot of that, and this may get lost in that clutter. So we want to make sure that people are hearing from trusted messengers like Alliance for Aging Research, National Health Council, MapRx, but more importantly, the actual patient groups we're working with, so that people who are involved in the American Heart Association or diabetes or lung or whatever, making sure that they're hearing from their providers. There's a lot of work here that needs to be done to make sure that providers know when they're actually making that prescription. They know when they're prescribing something that tends to cost a lot, and they can direct people that way. And also the pharmacist. We know that's what it hits when you get the bill. When you see it come up on the, receipt at the pharmacy counter. So making sure they're educated and they can help people, direct them and guide them. Are really important pieces. So there's a whole world around navigating Medicare that has arisen over the years, in Part D particularly, and all aspects of that are going to have to be utilized in this.
Yeah, I mean, it never, yeah, there's just, the stakes are so high to ensure that the materials that are put out there are high quality, are based on facts, and just because there are so many programs and people out there that are looking to take advantage of people, unfortunately. So it's important that people get their information from high quality sources like Medicare.gov, like patient organizations that have worked closely with CMS during this whole process, like NHC, the Alliance, NHC, and other patient advocacy groups. So we're excited to be a partner with all of our fellow organizations to help make materials available, because it's going to take a village to make this education really work. We do have a question about the URL. It is www.loweroutofpocketcosts.org. I think if you type in com, it will also get you there. So loweroutofpocketcosts.org, and there'll be additional resources in the coming weeks from our partner, from other partner organizations that'll be coming available. So we're all kind of sprinting towards the finish line of open enrollment, which is really the starting line. So I guess with that, we're nearing the closing time. So Jennifer, just wanted to ask if you have any closing comments for the audience today.
Just thank you all for being here, and we will make this happen all together and only all together. So anything we can do as National Health Council to help advance that, help you guys be good advocates and partners to people you're working with, we're here to do that.
Yeah, absolutely. And I think, not only on this, I know we talked about kind of the trusted partners, but yes, please reach out to us. I have information both for Jennifer here, her email address, jdexter@nhcouncil.org. And then I'm actually, my time, unfortunately, at the Alliance is coming to a close soon, but we have a fantastic public policy manager named, her name's Adina Lasser, and she can be reached at agingresearch.org. And we'd certainly be happy if you have additional questions that you didn't think of during the webinar that come up later. Please let us know. And also, we're happy to provide resources, especially, if folks want to send them out to patient populations that they work with. If you're on the Hill and you're looking for resources to send out newsletters about these coming changes to the Medicare program, we're happy to be of assistance. So, again, we just want to thank you so much for joining us today. And Brendan or Ashley, anything from MNQF before we wrap up?
Nope, I think we made all of our remarks in the beginning when Brandon spoke.
Awesome. Well, thank you so much for joining today's webinar, and we'll look forward to seeing everyone soon.
Thanks, guys.